So it's my honor to be here to talk something about the safety and the feasibility of PFA in PSVT. Okay, it's a very it's not very new topic, but I will show you more information about this. So everybody knows that the PFA has been widely used everywhere, especially in atrial fibrillation. Okay, so if you want to talk to a patient, if you want to talk to a doctors, how PFA can do atrial fibrillation? Oh, it's 100% could be okay. So can PFA can do other things? Yeah. So this is another questions we want to know. So why we do PFA in PSVT? Okay. So when 3 years ago, when we first have this idea, I also asked some professors, and they told me, okay, you are so crazy, you are so stupid, because the RF, yeah, if you use a radio frequency to do PSVT, it's a very high successful rates and also low complications, or maybe very low complications. So why do you want to do this? You want to be a cyber star? Okay, I told him, okay, so here I want to say why our centers want to do this, because we have three reasons. This is the first reason is we want to expand the PFA, because we know PFA can do in atrial fibrillation. But PFA, whether PFA can do in PSVT, we don't know. So we have to know that. Another thing that we know about what the energy source about the RFA and the cryo, but we know little about PFA. So we want to know the characteristics of PFA. The second thing is that we want to clarify the impact of PFA on the cardiac conduction system. So this is why we do this and why we stand here today. So, but PFA to PSVT, it can do or not. Yeah. So it's before we do the clinical trial, we just search a lot of search from the PubMed. We found there's no any reference. There's no any literature. There's no any experience from we can learn from. So there's nothing. It's zero there. So before we do this clinical trial, we have to do a lot of animal research. So before that, we just use a lot of animals, both dogs and pigs, and to test in the conduction system. Every ablation site from the PSVT, and we test many times to know where is the lowest potential, where is the highest potential, which energy we should use. So we try many times, and we know, okay, which position, which different type of PSVT has different energy source, has different ablation site. So I show you some cases. This is the first case, is PFA for AVRT. So this is a before, okay, this is a normal ECG of the patient. It's a science reason, it's okay. And this is a episode. It's a typical PSVT, so it's very easy for us to know this. And this one you can see, okay, this is a episode in EP mapping. It's a AVRT. And here, the first step is we make a 3D mapping system, and we measure where is the location of the bundle of keys, and then okay, where is the very early, okay, early retrograde A wave, and then we find here, and then we give ablation here. So this is a target, it's a ablation target here, and we give PFA here, pop, and then you can see the retrograde conduction totally blocked, okay. And this is a ECG for 1 month after PFA, it's normal. And 3 months follow-up Holter and echo is also normal. And also we do stress echo pacing, because we know, everybody knows that the PSVT not episode every day. So why this patient has been cured or not, you cannot know. So all the patients to do this clinical trial, we have asked all the patients come back to our hospital to do chest figure repacing. So we can do S1 stimulation, S1, S2 stimulation, something like that. So we want to know whether with this stimulation can help us to find whether it's been totally cured or not. So it's a negative results. And this is 6 months follow-up Holter, it's also okay. And also the patient don't have any episodes of symptom, and also no palpitations, no other symptoms about this after PFA treatment. So this is the first case. Another one is PFA for pre-exciting syndrome. It's very useful, very interesting cases. So from this is a pre-exciting syndrome. So I think everybody knows this. So if you get the first slide of this ECG, we know it's a very hard, it's a very difficult case to do because the ECG in V1 is totally QS. That means in the septum, and the R wave in both lead 2, lead 3, and lead AVR are positive R wave. So it's an anterior lateral position. So this is a very dangerous position if you use radio frequency to do ablation. So if you see the ECG, you know it's a very complicated cases. Okay, so this is a ECG before go to the hospital. This is one. The patient has been admitted in our hospital. It's the same ECG. Okay. And this is an episode AP mapping. Okay, it's totally AVRT. Okay, and then also the first step we first mapping the location of band of His, and then we find where's the early A wave. Okay, so here we found the target here. It's very close to the band of His, and also we give ablation here, and after that. You can see that this is before. This is AV. It's very close, and after PFA, the AV totally separated, and also the retrograde conduction also totally blocked, and then this is a PFA after this PFA treatment after 1 month. So this is ECG is totally back to normal, and this is 3 months follow-up. The heart rate is also back to normal, and echo is okay. And also we do chest echo of patients. It's nothing to find. It's a positive negative results. And also 6 months follow-up is also okay. And then it's another case for PFA to AVNRT. Okay, so this is a ECG before episode. It's a totally normal ones. And this is a episode ECG. Okay, you can see that. If you get the first slide of this ECG, you can see it here. The V1, you can see the fake R wave, and also both lead 2, 3, and AVF is a very fake S wave. So if you see this one, maybe more than 99%, so this one is AVNRT. Okay, so this is a EP mapping. So it's a typical conduction jump from the fast pass to the slow pass. It's very typical, and then this is an episode typical. This is an episode EP mapping. So when the EP doctor sees this one, you cannot do the differential diagnosis. It's a typical SF, snow fast AVNRT. Okay, because the A wave and V wave just come together. So what we do? Okay, the first one is also we located where is the location of band of His, and then we from the tricuspid and also coronary sinus, and all this from the lower position to the higher position to do the ablation. And after that, we give the ablation here. So after that, you can see this is a EP verification. There's no any jumping here. So the snow pass has been cured. And this is ECG after 1 month from the PFA, and this is 3 months follow-up echo, and heart rate could be okay. And also this is chest echo of patient is also okay. And this is 6 months follow-up heart rate, and you can see nothing here. So we summarized the 30 cases of AVRT. We published our results in JKEP. Okay, so the 30 cases is 100% successful ablations, and no any AVRT, and no any AV block need to be due to the pacemaker device. So this is a primary feasibility and safety in patients with AVRT. You can use this new method to do the ablation. And after that, okay, another Chinese centers, Professor Chu Huiming gave us similar results. He has summarized the 40 cases of AVRT. You can see that one. It's also 100% immediately successful rate, and also, but the junctional rate was induced. 80% patient has junctional reasons, and the safety is no. We can find transient AV block, but there's no any permanent AV block. Okay. This is another also from Dr. Chu Huiming about AVRT. Okay, 10 cases has been published in Europace. Okay, 10 cases of X-ray pathway, 9 left and 1 right. Also 100% successful rate, and also no other complications. Another group from Italian and also summarized the 40 cases of X-ray pathway. 8 left and 6 right, also 100% success rate and full approval. More than, okay, the longest case, more than 15 months, no related complications. So we, maybe 2 years ago, we arranged a multi-center and prospective single-arm clinical trial in 8 big hospitals in China. We arranged 158 patients of PSVT. We do the same thing. This paper has been accepted by Circulation AE. So in this papers, we show all the AVRT, AVRT, and WPW syndrome. So this is the result. You can see this. Okay. So both the AVRT, 77 cases of AVRT, 100% successful, and we try 2 energy sources. Sometimes if the location is very close to bound of His, we just use only PFA. We use pure PFA. If the accessory pathway very not far from the bound of His, we just use the 2 energy source. So you know that many companies, many factors have a product of dual energy. That means just for example, SDSF dual energy from Biosense Webster. So can give us both PFA and RF. So we use this. But we don't know whether this both energies. If we use this both energies to treat the PSVT, we don't know whether it's good or not. So we try 47 cases. The results is also very okay. So only 5 patients has a recurrence. More than 96% of the patient got a very 6 months post-operative success. So this is my summaries. Okay. So the preliminary clinical application of PFA in PSVT has gradually showed the basic safety and effectiveness. Okay. But especially in some very special anatomy locations, it may be safer than the traditional energies, especially close to the bound of His, something like that. The second thing is that the ablation parameters used in PFA products from different manufacturers has different parameters. So if you want to do the clinical trial, we use different parameters. Before the clinical trial, you have to do more animal tests to know whether is the lowest potential, where is the highest potential you will use in this, you will use in the clinical trial. Another one is that at present the sample size of the clinical trial has not very big, and also we lack the RCT. Okay, so if we want to further give us confirmation about whether PFA can do in PSVT, we need more samples, we need more RCT clinical trials to give us the answers. But the preliminary one showed us, okay, you can believe the PFA can be used in PSVT. Okay, thank you so much. This is what I want.